As Tara said, we're now going to move into the nurse perspective on things, and so we're going to focus on lifestyle modification and diet. And to take us through this here today from Adventist Health, please welcome Certified Diabetes Educator Cheryl Ortner. Cheryl, welcome.
Thank you.
Thank you.
So I'm not quite sure why it's so important to know what I do every day, but I can tell you that the numbers of patients that I see can vary anywhere from about 3 to 18 in a day, depending on what it is that I'm teaching. If I have a class, I might have as many as 10 or 11 patients in that class, and that would be like in the morning, and then in the afternoon I might be seeing several other patients, so it can add up. And the length of appointment times can be anywhere from 5 or 10 minutes up to 3 hours. If I'm starting an insulin pump, and especially if I have an older patient, it takes a lot longer for them to understand it and to walk through the different steps. And the different types of appointments, I do pump starts, I do CGMs, which is a continuous glucose meter, pre-classes, we do insulin starts, we do obviously the education classes, and I happen to be wearing the latest model of the Medtronic's pump. I haven't played with it that much, so the rep said, put it on, I want you to be playing with the numbers. So, you know, part of my job is to be the guinea pig, and Dr. Bertheau one time he says, I want you to try the Byetta. So I tried Byetta for a week. And understanding that Byetta is not a drug that makes your blood sugars go way down into the basement. It just kind of takes you down to a normal number. You know, so sometimes we're guinea pigs just to see what they feel like, what they, you know, all of that kind of thing. But I feel like it's the best way for me to be able to educate my patients if I have experimented myself, if I've worn the equipment so that I can understand it well enough to teach it. So carb counting. You know, in an ideal world, we would have everybody doing carb counting, but I am sure you have met those patients that you really can't do carb counting very well. How many of you are familiar with carb counting? Okay, so quite a few of you can do that. You know, what I like to do with the carb counting is that I just make sure everybody knows that one serving is how many grams? 15, aha, there are people here that know. So if people know how to do the carb counting, it's very, very helpful. There are some helpful guides out there for people, and I know that you do kind of on-the-fly teaching sometimes as well. So, you know, Merck has this Count Your Carbs Getting Started little booklet, and then Lilly has this daily diabetes meal planning guide. This is the one that I use for almost every single patient that comes into my office because it has a lot of exchanges and it's very small and there's no charge to it, you know. So I'll pass it around so everybody can look at it. In fact, I'll pass them both around. But I like it because then I can talk to people and just be sure that they have something in hand when they leave. The other thing that is in your packet are those 1,500 and 1,800 calorie meal plans. And so what I do with that is I use that and I use the Lilly book and I say, okay, well, what is a starch? And it gives an example, like for breakfast on the 1,800, I think it's 2 pieces of bread. And so then we talk about, well, maybe you never eat bread for breakfast, you have oatmeal. You know, well, then we look in the Lilly handout and we say, well, a half a cup is a serving for 15 grams. So, you know, and I refer to it as their bank account. You know, and you don't want to overdraw your bank account. So if your bank account says you can have 45 grams for breakfast, then that's what you need to have because you don't want it to bounce. And it's just a way that most people can understand not overdrawing their bank. And for me, it works really well as an example. But you've met those people that can't count the carbs. And so when you have those individuals, what we do is we say, okay, well, how many carbs are you eating? You know, well, I'm eating a bread and I'm drinking some milk and I have a piece of fruit. So we say, okay, well, we want you to eat very consistent meals then. We always want you to eat about 45 grams for your meals and about 15 grams for your snacks in between, and that's something that most people can then be consistent with. I skipped reading labels, okay. So if you're looking at the label, what is the two things that you look at first when you look at a label? Serving size. Total carbs. I heard it back there, yes. And so if it says total carbs are, say, 22, and the serving size on that Lilly book, it says that it's 8 crackers. So I always give them, I say, okay, well, if it says 8 crackers, maybe if you ate 6, that would be close to 15. You know, it's just kind of helping them see what they could do differently to make it match closer to that 15 number. And then the other thing that's on there is talking about consistent meal timing. And I think that that's really important for a lot of different reasons, but if a person is taking insulin especially, and especially if they're taking a mix like 70-30 or 75-25, that insulin is going to come in and be working whether or not they eat. So it's really, really important to be very consistent in their timing. The other thing that's not listed on here that we really emphasize in our department is eating high fiber. You know, so that when they look at their label, not only are they looking at total grams and looking at what the serving size is, but we want them to look at, well, what are the total grams of fiber? And if possible, make the fiber higher than the amount of sugar. So it's just kind of like a little rule of thumb that when you're looking, try to do that. Now, there are some foods that have no fiber, well, practically no fiber, like usually yogurts or something like that. So occasionally it's going to be okay to have no fiber, but for the most part, you know, looking at the amount of fiber is going to be really important because fiber stabilizes the blood sugar so well, which I'm sure you guys know that. But any questions about that? Kind of basic. But I know that we really emphasize a lot of fresh fruits and a lot of fresh vegetables. But how many of your patients are involved with Weight Watchers when you go and talk to them? Anybody?
It's too expensive.
That's
for
true.
Patients, I never had a patient of 14 on Weight Watchers for that reason.
Very interesting. That's a good point, that it's too expensive for most people. A lot of patients, when I do start talking to them about carb counting, they'll tell me that it's the same as Weight Watchers. And if you ever should run across somebody that had it in their history, the difference is that Weight Watchers does not count fruit as a point. So that's the biggest difference between Weight Watchers and carb counting, is that obviously for people who have diabetes, they need to consider that fruit is, quotes, a point, or carbs. The other thing that I like to do, you know, if you're talking about consistent carb counting and you have somebody that just doesn't get it very well, if you generally say, well, if you consider a serving size about a half a cup, I mean, if you go through there, you know that it's not always a half a cup. I mean, you know, for rice, it's a third of a cup, and for some things, it's 2/3 of a cup, or it's a cup. But for most people, if they just kind of group it as a half a cup, if they can't count carbs in the traditional way, it's at least a rule of thumb that will get them through and help keep them as safe as possible. So it's another way of kind of making consistent carbs at a meal. Because sometimes it'll be less, sometimes it'll be a little bit more. There's so much you can talk about diet that it's. So if I have 5 minutes that I can talk to a patient and I'm talking to them about their diet, obviously I'm not going to be able to get into a huge amount of carb counting, can I, in 5 minutes? So the approach that I usually take is I ask them, what are you eating? And I get them to tell me what they eat, and then I calculate out for them what those carbs would be. Especially if I'm starting somebody on a pump, and I know how to count carbs, but then when I start to work with them, it's obvious to me that they really don't get what carbs are or how to really count them. And so I obviously will get them connected to my dietitian as quickly as possible, but we have that 5 minutes that I can talk to them. So I get them to telling me what it is that they're eating, and I tell them, well, how much of it do you eat? And I get my little cup measures out so that they can actually see what it looks like. And then I give them the grams. I said, okay, well, that would be about a half a cup. Well, that would be about a cup. And then we figure out what they're eating. And a lot of times they're not doing that badly. And so then I can reward them and say, wow, you're doing a great job. But, you know, sometimes they're really messing up on a certain area. And so I go, well, this might be an area that we could improve on, you know, and then we talk about how many grams there are for that. And to me, it works really, really well when I'm having to go in and be in a big hurry. The other side of that would also be to stress the fiber. Because if they're eating a lot of high fiber, it's going to help even things out. There's a lot of people that just don't realize that rice, you know, is so high and can cause their blood sugars to jump so high. Well, all I ate was, you know, a cup of rice, I had a little rice, and, you know, and then I had the sweet and sour, and you know, well, when you start to talk about how much they actually ate, they maybe have eaten 120 grams, but didn't seem like very much to them because it was mostly, you know, vegetables and a little bit of rice. But there was a lot more in it. And how to exercise. This is a big one. I used to work in the cardiac rehab program. And when I worked in the cardiac rehab program, we came up with some specific guidelines. If a patient's fasting blood sugar in the morning was good, but when they came to the clinic, it was high, probably the reason it went up was because they ate something, right? So we know that if it's gone up because they ate something, exercise is going to help it, right? So we usually didn't get too excited if the fasting blood sugar in the morning was normal. So we'd say, oh good, let's just see what it looks like when you've exercised, and usually theirs just went down really nicely. So for a type 2, if their blood sugars were 300 or less, we would let them exercise. If we had a type 1, what we would do is we would check them for ketones. And if their ketones were negative, but it was 250, we would let them exercise because, and their fasting was normal. It always goes back to what their fasting was when we're looking for exercise. Because if their fasting was good, chances are that what's causing it to go up is more related to the diet that they had rather than anything else. Now, if they're coming in really high in the morning, then it's telling us that there's more out of control with what they're doing, and they may need to be seeing their doctor before we do a lot of exercise with them. Does everybody understand that principle of why we wouldn't want to exercise somebody that has ketones? Okay, I'm not hearing any, okay.
But I'm wondering why we wouldn't exercise somebody who had a high fasting.
Well, if we have a really high fasting, it's giving us much more a where are they at their normal. You know, because if they're running out of control to start with, then we're going to be wanting to know they're probably not getting enough control of their insulin levels. And we may need to be fixing the basic problem. You know, if we know it's a diet thing, then we know that we can take care of that with the exercise. But well, I mean, you could ask a lot of other questions. I mean, if it was just this morning that it was high and you know, but why would you sometimes have a high blood sugar in the morning?
Well, you ate a lot the day before.
Okay. When is the lowest blood sugar of the day? Pardon?
So there can be a middle of the night low that gets you a really high in the morning.
Exactly.
That's your response.
Mm-hmm. So the lowest blood sugar of the day is between 1 to 3 a.m. So people go to bed, you know, and they say, well, when I went to bed last night, it was 103. And I woke up this morning and it was 250, and I did not eat anything. Well, to me, I suspect immediately that they had a low blood sugar in the middle of the night, and it was their body helping to bring them back out of it that got them in, you know, up that high. Especially if they say, well, normally my blood sugars aren't that high in the morning. Then I'm going to be suspicious of that. People who are taking Lantus or Levemir. I tell them that what I want them to do is to take a bedtime snack. Because I know that, well, especially like for Lantus, if it's going to have a low, it's usually at 4 hours. So if they're taking that little snack before they go to bed, it's going to help prevent that low between 1 to 3 a.m.
So I guess just what I'm thinking of is, educating patients, because I don't work in cardiac rehab, I work in primary care, So
Right.
patients who don't have consistently controlled sugars, would you advise against exercise until the sugars are in a normal range?
Not generally. I mean, I would encourage them to get out and to start exercising. When we exercise them in cardiac rehab, we were kind of, obviously we don't push them too hard because they just had a heart attack or whatever, but we are making them pour out effort. And what a person talks about as exercise many times really is different. Some people, it's just like, oh, hi, I'm out here exercising today. You want to, and they're just kind of wandering around, and it's not truly what I would call exercise. It's moving, and it's nice. It does help with blood sugars that they're moving, but it's not like we would do with cardiac rehab. Now, if a person's in there and they're consistently doing it and they're breaking into a sweat and, doing things, that is more what we would call the cardiovascular effort. And that's generally going to take the blood sugars down a lot more than the meandering around. So it depends on your patient and their level and all of that kind of stuff, but I like them to know how out of control are they to start with. And if they're really out of control, they need to talk to their doctor. But starting an exercise program that's a low level, walking a little bit, probably isn't going to hurt anything.
I might be off on my path of, but don't muscles usually readily accept sugar a lot faster than other body tissues though? So wouldn't it be a good thing to get them?
It generally is a very good thing. If you have a type 1 and they don't have enough insulin on board, then what happens is that they're breaking the fat down to get more sugar, but that's just making it worse because they still don't have the insulin to absorb it. Whereas with a type 2, generally, any kind of movement is going to help take it down. But if they're way out of control, it's still probably not a good idea to push it too far. What is way out of control with a type 2? Well, in cardiac rehab, we chose 300 as being that number. Just because it's more effort for the body to then work. And there was some scientific studies that we looked at to come up with those numbers. But when I talk to patients about starting an exercise program, I tell them, well, how much of a drop do you have when you exercise? If you have big drops when you exercise, then you might need to be taking a snack ahead of time. But what if you're taking insulin? If I'm trying to lose weight, isn't it a little self-defeating then to have to eat something?
You always have to eat something. It's inherent, so time it so that it works with your insulin and your exercise. We all eat.
So we all need to eat. All eating is good. However, if I'm having to eat extra snacks because I'm exercising, it's not going to help me that much with my weight loss, other than to increase my metabolism. I mean, there are some benefits, but what a person can do if they're taking insulin is reduce the amount of insulin that would be affecting that exercise period. So if I'm taking fast acting at breakfast, and I know that right after breakfast, in an hour or so, I'm wanting to go to the gym and work out. Well, I can take less of the fast acting at breakfast time, allow the food from the breakfast to then be what's being absorbed a lot in my exercise session. So there's, you can do that. For people who are taking NPH, when it's peaking is more towards the afternoon, well then you can reduce the amount of NPH in the morning so that it will help decrease that in the afternoon when I want to exercise. If a person is exercising on a long-term basis, they may need to reduce something like Lantus a little bit overall, just because now they have that active metabolism that's decreasing it. So insulin can work to help you for those patients that are really trying to lose weight. If a person is trying to maintain or actually gain weight, then you use that eating part of it to their benefit. You go, okay, we're going to exercise. You need to eat something to help, maintain it.
So that amount of kind of self-adjustment and sophistication and thinking about how are my carbs used with exercise versus what I'm eating versus how much insulin do I need, from like hearing that as a nurse who helps patients monitor their diabetes, that like makes me break out in a sweat. You just have like no idea what on earth your patients are doing and helping them figure out what's in control and what's not, and are they low or high. I mean,
It's
that's
scary.
way too much variability. So I would assume that what you're talking about is really for patients who either have been diabetic for years and really have a good system of control, or have a level of education and health literacy that would allow them to really understand what they're doing as they kind of move around their regimen.
If you are ever in doubt, you just tell them if your blood sugar drops when you're exercising, eat a snack before you do it. What we did in cardiac rehab was we would sometimes give them a little container of juice, and because we did like segments that they would do, they would be on the treadmill for a little bit, and then they would be the arms and the legs and a rowing machine or something. We'd say just take a sip of it between each exercise. That way they're not getting over amounts of intake, but it's maintaining the blood sugar during the exercise.
And then a little bit of biochem. So I thought if insulin is being activated, you can't break down fat. So you're using one of the, it's either, what is it, glycolysis, and then insulin, or what is it, glucagon, and then insulin is shut off, and then if insulin's active, the other one's shut off, right?
So they're going to be having insulin on board no matter what. I mean, if you've given somebody Lantus and they go exercise, the insulin is there.
Right.
But we still find that when they're exercising, even though they have insulin on board, that they do use their sugars more easily. So it is being used and absorbed more quickly.
I'm sorry, I meant for fat breakdown though. Like I don't think you can break down fat I can't remember what the process is, but I think if insulin is active, the other one can't be active. And then the other one is active and the insulin is shut off.
Because if the body's getting its energy from the sugar in the blood and using it actively, then it's not
Breaking
breaking
down
down
fat.
fat in
To
order
get
to
it.
get sugar in
Right.
order to function.
Right.
Yeah.
But I don't know how that would interact with the weight loss part. Yeah.
We know that when a person is exercising, it still helps them with weight loss, but you don't actually exercise to lose weight. It will build muscle. Muscle weighs more than fat, but overall metabolism is increased.
Okay. So it's just increasing the metabolism.
So like if you exercise and I never exercised and we were both sitting at the table, you would be burning more calories than me because you exercised all the time. Just because overall it does help it. Am I okay on time? Okay. We wouldn't let people start an exercise program if their blood sugars were less than 100. We would let them exercise for the day, but they had to have a snack. And that's one of the big reasons for having them test before and after, because it helps you to know, how low are they starting, and then how far do they drop with the exercise. A lot of patients aren't going to do that forever, but at least if they get a good feel of what their blood sugars are doing. If a patient, I don't know, do any of your patients have the continuous glucose meters? Because it's not, okay. Sorry. I really like them.
Can I ask you a quick question? So what I've read is that the difference between type 1s and type 2s is that type 1s, they can have that leg effect where they exercise vigorously and up to 24 hours later they can have a low because of it. But my understanding that type 2s, I don't know how immediate the effect of exercise is, because I've had patients check after exercise and they didn't notice a difference at all. Or
In fact, it can be up, right?
Yes, because especially if they're competitive, then they're getting all excited about what they're doing. But I was just wondering, does that leg effect affect type 2s?
They have some delayed too, but it's more type 1. But this was something that I learned a long time ago, and it was that the first 20 minutes of exercise, you're using the sugar that's circulating in your bloodstream. The second 20 minutes, you are using what you're getting from your liver. So your liver is kicking in and giving you some blood sugars. And so that's when you can see the rise in the blood sugars. And then they say that the last 20 minutes is where you're starting to break fat down. Now, it was just a rule of thumb, and it was a long time ago, and I'm not even sure that the validity of it is still out there, but it does make sense that at least it talks about the systems that can happen. Whether they're all in those nice, neat little 20-minute segments is a whole different thing, because I can see it would be different. If I ate a very large pasta meal and I decided that, well, I'm going to give myself 30 minutes and then I'm going to go out there and I'm going to, really exercise because I ate all that pasta. And probably my blood sugar is going to be higher longer than 20 minutes because I ate a lot of pasta. It's like when you're going to the spaghetti factory and you give you the big boys, right? Or what are they called? Hardy boys, I think they're. It's going to keep that sugar up there high for quite a while. The dietitian that I work with, she says, well, they have to earn their dessert. So they'll eat their meal, then they take this 2-mile walk over to where they get the ice cream cone. They eat their ice cream and then they walk home again. So they've walked 4 miles for their ice cream cone. They've burned them. And so I think that it's just understanding that if you test, sometimes it's not going to always be less, but ultimately it will be down. Usually at 2 hours it will be down. And the things that I have heard, that it can be down up to 4 to 6 hours after you exercise, again, depending on how strenuously you've been out there and exercising. For people who are training for triathlons or for, some kind of a marathon kind of thing, theirs can be down for at least a good 24 hours. And sometimes they even set up to 3 days. It's what I've been hearing in some of the literature. So, it can be down for a while. I have had some kids that play games like soccer or, where they're really running when they're doing it. And they will a lot of times have lows at night because of that. So it's really important for a kid that really poured it out during the daytime to make sure he has a hearty snack before he goes to bed, or even decrease the amount of insulin that they're taking during the night. And you can do that if you have an insulin pump. You can just decrease the basal rate during that period of time, but you could also do it in ways of decreasing the amount of the basal insulin for your day as well. Any other questions?
I have a question.
Sure.
So you talked about rice a while ago. You see a lot of patients, a lot of Hispanic patients, that obviously that's a huge piece of their diet. Is brown rice any different? Is it?
So the brown rice.
I know it's different, but.
Right.
Is that like maybe a baby step?
It's a huge step better.
Okay.
When I'm describing it to patients, I say, okay, this is eating white rice. Womp, womp. You get this big rice and it's down. If you're eating brown rice, it's womp, womp. So you got a lot lower rise in the amount of sugar that comes through with it. However, the serving size is still the same. And it's because they do absorb it over time. So we still say it's still 1/3 of a cup. But I always talk to my Asian friends and I tell them, I know from talking to my Asian friends that 1/3 of a cup is not generally what you eat. I said, and I have a lot of people tell me, pardon?
That's cooked, right?
That's cooked. That's cooked, not the raw, unfortunately. And and they'll many times say, well, I could easily eat 2 cups of that. And that's not just my guy saying that, So, well, that would be 6 servings right there. So, it's understanding that what is comfort food for people and that kind of stuff, and then addressing it so that they understand that It's not that I want to take your comfort food away from you, but how can you eat your comfort food in a way that's not going to make your blood sugar spike so high and get you in trouble?
And that's because of the fiber in it, correct?
The fiber in the brown rice really makes it go down lower.
I've had patients take kind of a baby step of mixing the white and brown. The brown.
Yeah. It has a whole different texture to it, and it is, and if you've always been, this is my family, always cooked white rice for me, and suddenly you're putting this foreign product in front of them, it doesn't feel like rice. So the baby step of mixing it is a good one. Mm-hmm.
Do you often talk about glycemic index with patients, or is that just kind of going over the top?
The glycemic index is now kind of not the important thing. I mean, they put carrots way up there at the top, and I don't know if you saw the thing that was circulating, carrots are actually on the free list. And it's because it has a lot of high fiber in it. But what I will tell patients is that we say that free list is that they can eat it as much as they want, the non-starchy vegetables. However, you can have a cup of raw carrots mid-morning, a cup at lunch, a cup mid-afternoon, a cup at dinner, and a cup at bedtime. However, don't eat them all at one setting because it will take your blood sugars up. So I do address the glycemic index indirectly, but they were taking off foods that were good for people and stuff just because of that, and so they've kind of backed off of that being the focus.
But like, for example, if they wanted to eat an apple and they're choosing like a Gala or a, Granny Smith or something, quite a bit more sugar in it, but I don't know, not really.
What I do when I'm talking to patients is talk about serving sizes a lot. This is the serving size of an apple. Most apples in the store, you get them about this big. So if you think about it as a half an apple, well then that's about a serving size. And I think that helps people to understand it better, that, oh, I can still eat them, it's just how much of that I'm eating. I think serving sizes is the big thing, because people will tell me, oh, well, I just had a glass of milk. And, what is a glass of milk? It's supposed to be 8 ounces. But most people's glasses that they drink out of are 12 or 16. I've had patients tell me, well, I just chug, a couple gallons a week, And I have to tell them about what is a serving size. And most people, when they take their quizzes in my classes, they still forget that milk is a carbohydrate. It's a protein, it's a fat. They don't think of it as something that raises their blood sugars. And a lot of people don't necessarily think of fruit as being a carbohydrate. They got that bread, they got that starchy stuff down, but.
Actually, I run into a lot of people who are older, who are very concerned about fruit, and think they can't eat it because they're diabetic.
I have heard it that way too.
So it's an interesting dynamic though, because it is a carbohydrate in one sense, but it still has fiber in it.
Mm-hmm. And minerals and vitamins and all of the other stuff. So.
Right, but you still advise counting the carb grams.
Mm-hmm.
And so is a general guideline like a piece of fruit is 15 grams?
Okay, so if you're talking cherries, it's about 12 cherries. If it's grapes, it's about 17 small grapes. If there's a great big grapes, then it's more like the cherry count, like 12. If you're talking watermelon, into cup measurements, it's like a cup and a fourth. One thing that I like to tell patients though is if it's a compact fruit and you can squish it into a half a cup, then it's pretty much across the board, except for melons. So like if you have blueberries, it's 3/4 of a cup, but they're round and have space between them. If you have raspberries, it's a cup, but there's a lot of space in there. If you could squish it easily to a half a cup, that's probably it. Strawberries, it's a cup and a quarter. But if you take fresh strawberries, so if you core it and slice it, oh, that's about a half a cup. So, if you think of it as about a half a cup, then when they go to a store or they go to a restaurant and they're getting fruit, they go, oh, it's about a half a cup. I can do that. Or if I squished it down, it would be about a half a cup.
With the counting, we have these really great lists, and I don't even know where they came from, but starches, fruits, milk, and it lists one portion size, so 15 grams of carbohydrates. Does the Lilly resource have anything like that?
That is,
A list of portion sizes for common carbohydrates.
so that, did that list
It
go
hasn't
all
got
the way
to it.
around?
So this thing is what I show people a lot.
The plate, the plate method, yeah. But in the Lilly thing, it does go through step by step, and that's why I use it so much, because it gives them, what I tell them is that you can have any starch as long as you use these serving sizes. Same thing with the fruit, same thing with the milk. And then that way they have a really good, clear idea. The other thing I do with diet really quick, because I can see he's wanting, is that I start talking about heart disease day one. Because I tell them that diabetes is a risk factor for heart disease. So you need to be thinking now about reducing your fatty meats and reducing the saturated fats. I mean, it's just good health information anyway, but I connect it to the fact that they're going to be more at risk for heart disease. And so that it's going to make it better for them. Was there one more question? And then I thought I had seen a hand, but okay. Thank you.
Let's give it up for Cheryl.